friends, this is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, in this video I want to talk about the effects of a high salt intake, the effects that it has on blood pressure control. The effect of high salt intake with regards to blood pressure control, right? So okay, so guys, as doctors we always advise patients to reduce their salt intake when they are hypertensive or when they've got heart failure. There are even patients that we have actually go on and advise them to stop taking salt. Not even reduce it, but to just stop taking salt. What's the reason behind that? What's the issue? How does a high salt intake affect blood pressure control? And how does it worsen heart failure and the symptoms of heart failure? Okay, so in order for us to understand this, we need to go back and talk about the RAAS system, renin angiotensin aldosterone system. So this system, when does it get activated in the body? So when there's hypotension, the RAAS system gets activated. When there's hypotension, the RAAS system gets activated. Hypotension, a reduction in blood pressure. Why does the RAAS system kicks in when there's hypotension? The body is concerned about maintaining homeostasis at all cost. So when you have hypotension, you run a risk of hypoperfusing vital organs. So hypotension can result in hypoperfusion of vital organs. Once you get hypoperfusion of vital organs, those organs are gonna die. You're gonna get so once you get hypoperfusion, you can get multi-organ dysfunction or multi-organ failure. You get your vital organs they stop working because they are being hypoperfused, and you end up losing a patient, or the patient complicates because of that. So, or the person. So when you have hypotension, you run a risk of developing hypoperfusion. It's not a must that when you develop hypotension you have to develop hypoperfusion, but you are at a risk. You can be certain. What determines whether the patient is hypoperfusing or not is the MAP. Once the MAP of the patient drops to less than 65, remember the MAP is the pressure at which organ perfusion occurs. So if this pressure drops, then you are going to start to see, you are going to start to experience hypoperfusion, and your vital organs will start to complain that they're not getting enough blood, right? So when you have hypotension, as long as you don't have a drop in your MAP, you are good, you are still fine. You will start to get a drop in your MAP and you will start to hypoperfuse, then you're going to start to develop multi-organ dysfunction or organ dysfunction. So hypoperfusion, when you get an MAP of less than 65, you can be sure that you are hypoperfusing. And the longer the patient remains, or the longer the MAP persists, the more damage will occur with regards to organ hypoperfusion and organ failure, right? So you can have hypotension without hypoperfusion. That's what I want you guys to get. And when you talk about critical medicine, the guys that are doing critical medicine, when they've got hypotension, it's not a train smash for them. They just look at the MAP. What is the MAP doing? Right? Okay, now when do you get hypotension? What are the causes of hypotension? I'm not gonna be able to remember all of them, but hypotension can result so hypotension can result from a reduced blood volume. So a patient can develop hypotension simply because they have lost blood volume. And now, how do you lose blood volume? You can lose blood volume by bleeding, hemorrhage, excessive vomiting, excessive diarrhea, sweating, and other mechanisms, right? You can also lose a lot of blood volume when you've got abnormalities with your 8H, when you are deficient and lose a lot of blood volume, right? You can also develop hypotension from when you've got some kind of, maybe you've got stenosis of the aortic the aorta. We've got stenosis of maybe the thoracic aorta. Yeah, let me say thoracic aorta. There's stenosis there, and you get hypotension, hypoperfusion, and also when you've got some kind of an obstructive lesion. Say you've got it can be luminal, it can be extraluminal, intraluminal, just a lesion just obstructing, and the other causes as well, but the most common cause is blood loss. So the RAAS system is there to make sure that in the event the body is experiencing hypotension, the RAAS system kicks in to make sure that this hypotension is corrected before the body gets into a state of hypoperfusion. And because we know that hypoperfusion will kill your organs and eventually kill the patient. So the body is aware that if I leave hypotension for long enough, I'll get into hypoperfusion, and then I'll get into multi-organ dysfunction. That's what the body doesn't want to happen. Okay, now what does the body do? The body's okay, so let's take it from here now. Now you've got hypotension, and the body picks it up, the afferent arterioles, the juxtaglomerular cells, your mechanoreceptors, baroreceptors, they pick it up that, okay, we've got hypotension. So now what do we do? So what's going to happen is that there's going to be the juxta cells are gonna release prorenin. Prorenin will be cleaved into renin. Then from the liver we get our angiotensinogen, which is a protein. This renin is gonna convert angiotensinogen into angiotensin 1. Angiotensin 1 will be converted into angiotensin 2, and that job is done by an enzyme called the angiotensin converting enzyme. Very important enzyme, right? And this happens in the lungs. Right? Now, what is going to happen is angiotensin 2 has got about 5 effects. It will act on different receptors, not different receptors. It's going to act on its receptors in different organs. And those organs, okay, let me put it this way. So the effect of angiotensin 2 is going to be, it's going to go, let's put our kidney here. And on top of the kidney, we've got our adrenal glands. So angiotensin 2 will circulate to the adrenal cortex, and the zonal glomerular cells are going to be stimulated to release aldosterone. Aldosterone, which is a steroid hormone. That's number one. Number two, aldosterone is gonna stimulate the hypothalamus, and it's gonna stimulate the hypothalamus, actually the thirst center. So the thirst center in the hypothalamus is gonna be stimulated. The patient is gonna have an urge to want to drink water. Thirst center. Number three, the posterior pituitary is going to be stimulated to release ADH. When you've got hypotension, what you want to retain as much water as you can in the body, so that you can increase the blood volume and increase the blood pressure, which is the problem that we have here. When your thirst center is stimulated, you're gonna have the urge to drink water. Then the more you drink water, the blood volume will increase, and then the blood pressure will increase. Hypotension corrected. And also, You don't want this patient to